So my name is Chris Curtis, and I'm the chairman and founder of the Swallows Head and Neck Cancer Charity based out of the UK. Welcome wherever you are in the world and whatever timeline you are at the world watching this presentation. I'd like to introduce Paolo Bossi, a medical oncologist, who is going to be talking about 4 abstracts from this year's ESMO. Paolo, over to you.
Oh, thanks so much, Chris. I believe it will be a good opportunity to discuss all together what happened during the last Congress of the ESMO, European Society of Medical Oncology, in order to understand how the research is changing also in head and neck cancer. These are the disclaimers, and these are my disclosures. So first of all, I would like to discuss with you a quite complicated study, but do not be afraid about this, because we will try to understand how it has been developed by the authors. So this French group performed a meta-analysis, an individual patient data meta-analysis. That means they analyzed altogether the data from different randomized trials, so the best trial you could perform, and evaluated the data patient by patient. So it's a really clear meta-analysis and a clear work with very important results. This is the good methodology to perform such an analysis. And they evaluated the role of this drug, this group of drugs that are antibodies anti the epithelial growth factor receptor, that we know is a receptor that is highly expressed on head and neck cancer. So, and it is also involved in the progression of this type of cancer. In the past, multiple trials have studied this class of drug combined to local regional treatment. When we refer to local regional treatment, basically we refer to radiation therapy, and not so much, but also sometimes also to surgery. And these are the results of this individual patient data meta-analysis. So let's go into depth. It looks like a quite complicated graphs, but it's easier than you can think, because all the patients treated in this type of trials with a good follow-up, so where the data should be consistent, have been analyzed if this type of drugs, this anti-EGFR drug, has been put only on top of local regional treatment or on top of local regional treatment plus chemotherapy. So the authors performed these 2 types of comparison. And the main endpoints are quite important, as they are the overall survival and the local regional distant progression and toxicity of this drug. So just to let you know that the number of trials and the number of patients evaluated was really huge, more than 3,000 per type of comparison. And these are the names of the anti-EGFR antibody. You see that cetuximab is the mostly used anti-EGFR agent. So the first analysis evaluated whether the addition of this anti-EGFR antibody increase the survival or not when put on top only of local regional treatment. So as you can see, there is no significant increase in overall survival, but only a small subgroup of patients, in particular the younger one, benefited more from the addition of these anti-EGFR antibodies. For the second type of comparison, so when you put this type of drugs also on top of chemotherapy and another local regional treatment, you may see that this has been associated with a decreased overall survival in comparison to chemotherapy. So when you compare a local regional treatment plus chemotherapy, or the same local regional treatment plus an anti-EGFR agent, you may see that the local regional treatment plus chemotherapy is better. So it looks like that the addition of the anti-EGFR agent cannot substitute the use of chemotherapy. So this is the main message. At the end of the day, what I would like to say, coming from this huge analysis, is that there was no survival benefit with the addition of anti-EGFR antibody to local regional treatment for either comparison. And in particular, replacing chemotherapy with anti-EGFR antibody as systemic treatment results in inferior survival. So what does it mean for everyday treatment? This means that for more than 20 years, we have been using one drug that is called cisplatin. This is a chemotherapeutic drug whose activity as a radiosensitizer is a very, very high. However, this drug is also quite toxic. As you know, cisplatin induces nausea and vomiting, may induce renal insufficiency, it may cause neuropathy, may cause may need to have a huge hydration. So it's not a drug that is easy to be administered. And so this was the reason why we tried to substitute in many trials this drug with an anti-EGFR agent. However, at the end of the day, we could say that every time we could use a chemotherapy like cisplatin, we should use it because it is the best drug. And the use of these other agents, the use of these anti-EGFR agents is good, or can be used only in those cases who are not eligible to cisplatin. So at the end of the day, this is my main take-home message. So continue to use this chemotherapy because it works, and leave it off only when you cannot use another drug. So what about Chris? It was a meta-analysis, so sometimes it's too scientific as a language, but the conclusions are quite easy to be defined. This drug should remain in the therapeutic armamentarium. I'm speaking about cisplatin, and this should be the best one. What do you think about it?
So I've got a couple of questions, as you would expect. I'm not a scientist. I'm just a normal guy that happened to have head and neck cancer, and now I'm talking to a very clever guy. And I'm sure there'll be people in our audience that do understand what you've just been talking about. But I'm going to try and get it down to the very basics. Just explain to me what an epidermal growth factors are. That was the first line that I got lost on.
Yeah, you're right. Let's start from the beginning. You're right. The epidermal growth factor is a factor that can induce the growth of something. And this is a factor that is present in a physiological way in our body because we need this growth factor for our cells to develop, to increase in a normal manner. However, sometimes the same growth factor is used also by neoplastic cells. So the tumor uses the same growth factor that are physiologically present to increase their size. So what we know is that if we try to block the receptor of this growth factor, so it's a sort of a key in the door, we try to block the space where this key enters in the door, and we put this growth factor away from the cancer cell. So this is the mechanism of action. I have a growth factor. I tried that this growth factor cannot nourish the tumor. This is the activity of these antibodies.
Perfect. Now I understand just three little words how it can confuse people. The other one is around I study a lot of trials when I get a chance to look at them, and they all come up with different numbers of what people have had in trials. So I think this one was around about 3,000 and something they looked at. So is there a good number that there is in a trial? So in other words, the 3,000, is that a good number of patients, or is it average, or should they be looking for more, or is there a reason why they couldn't get more?
No, good, thanks. This is a good way to proceed to analyze the trial. Usually, the trial that have examined this, that have analyzed the impact of these agents, have been performed on 400 or 500 patients at this maximum level. Single trial. What a meta-analysis usually does, it's enlarging the number of patients by putting all these trials together. So this 3,000 patient is a really huge number of patients. And the conclusion that can be drawn from these numbers are quite important, and they should be considered as state-of-the-art in the treatment. So if you see that the cisplatin is better than this agent, this anti-EGFR agent in 3,000 patients, you should say, oh, okay, this is quite an important number. Okay.
Because obviously with the number of head and neck patients that are out there going through treatment, 3,000 looks a small amount, but now you've explained that, I'm a lot happier that actually it's a very good number.
Yeah. So yeah, for sure.
That's two more simple questions, and I'm sure they'll be so easy for you to answer. The first one is, you talked a little bit about quality of life. As a patient survivor, quality of life is so important, during treatment, post-treatment, and into survivorship, if you're lucky enough to get to that length. Survivorship is not survivorship without quality of life. You talked an awful lot about things that may not be very pleasant with doing on these trials. Do you think that is a problem over doing the change for tomorrow?
Yeah, you're right. The way in which we are proceeding also to start a new trial takes into account the importance of the quality of life, not only during the treatment itself, because we know that every treatment has a toxicity that is typical of the mechanism of action of the drug or the therapeutic procedure, but also at the long-term toxicities, because we know that it is not enough to cure a patient, but it is important to give the patient a high long-term quality of life. And this is I would see that is in attention and a way of thinking that is typical of the last 10 years. And it's a way in which we are proceeding, where we are trying to start new trials where the quality of life is embedded in the main objective of that trial. So it's not, in the past we were used to say, okay, we have overall survival as a main endpoint and toxicity as secondary endpoint, or progression-free survival, many other endpoints. Now we know that quality of life in the short and in particular in the long term should be put as one of the main endpoint of the trial. This is a lesson we have learned, I have to say.
Good, and I'm glad to hear that. We run a 24/7 support line, and when a patient rings me up who's 70-something years of age and says, I wish I hadn't survived cancer, there's got to be something not right there with people not looking at the quality of life. So I'm glad now research is really starting to realize that quality of life should be right at the top of the list and not a tick box exercise. And I'm really pleased to hear that, Paolo. That's really good for me. So my last question is, and you may not be able to answer it, you may be able to answer it, how do you think this could change the pathway in the future?
I believe this could reinforce physicians saying that the drugs that are working in a good way should remain the most used ones. So this, in one word, cisplatin is the best radiosensitizing agent we have. So when I have a new patient with a good performance status, and I would like to offer the best drug in concurrence with radiotherapy, I know I have to use cisplatin. This is the message that I would like to give from this huge analysis.
Perfect. So when I first started doing these reviews, and I don't do a lot of the reviews because I'm not a scientist, like I said, but when I first started watching these and listening, people use the word toxicity. I hadn't got a clue what it is. Please just briefly explain to anyone out there thinking, I know what it is now, and I would imagine 99% of people that does. But if there's one person out there that doesn't understand what toxicity is, just give a brief description of what that means.
Thanks, because this is This is important for us as physicians because we use this term, but it's important to know that it's not so perceived in its meaning. So thanks for this, because sometimes I need that patient and patient organization could push more about the importance of using the right word also in this kind of context. So when I speak about toxicity, I speak about any adverse event, any type of consequence that a drug or any other therapeutic intervention may have outside its activity on the tumor, its beneficial activity on the tumor. So if a drug reduces the size of a tumor, but induces, I don't know, diarrhea, for instance, this is a toxicity for me. And I have to know that that drug is good for the tumor, but is bad for the diarrhea of the patient. This is just a stupid example, sorry.
That's an absolute perfect example, because I once had to ask somebody and I felt silly asking the question. But I think it's important that we get that over and well explained. So thank you for that. That's the only questions I've got on this at the moment, but I'm sure there'll be lots of other questions that people are looking online.
Okay, let's move so to the second abstract. This is a more conceptual abstract that could inform us for the use of another drug, how to better position another drug in the future. This is the trial that presents the long-term results. So 4-year results for us is a long-term results of the use of immunotherapy. Immunotherapy is a new class of drug trying to leverage on the immune system of any patient to counteract the activity of the tumor. And they try to put this new drug that has been found as a good drug for the tumor when it is in the recurrent or metastatic setting. But now we moved this drug into the field of the curative setting. So when we perform chemoradiation, we know that chemoradiation is a treatment that tries to cure the patient. For instance, a tonsillar cancer can be treated with chemoradiation. And the authors try to evaluate if we can improve the results of this chemoradiation by adding this immunotherapy. And they evaluated also in this case in a randomized ways. So one patient to one group and one patient by random chance to another group. They put this drug or concurrently, so during the same period of chemoradiation, or in a sequential way, so only after the end of chemoradiation. So this is basically the design of the trial. So 80 patients divided into 2 groups. This was a patient with we call as a local advanced cancer, so a cancer that is not in its first stage of disease. So it's a quite huge cancer, but also in a stage where we may try to cure it. And they evaluated, as I previously said, this drug called pembrolizumab, that is immunotherapy, together with chemoradiation, so in the same time frame, or after the end of chemoradiation. And what the authors evaluated is that the administration in a sequential way, so after the end of chemoradiation of immunotherapy, could be a better way for the control of the tumor. I mean, you can see the green lines are the lines representing all the patients that have received immunotherapy after chemoradiation, while the blue lines are the group of patients receiving chemorad concurrent with chemoradiation. And the results of this trial, as you can see, when a curve is lower, it means that the control of the tumor is worse. When a curve stays higher, means that the control of this tumor is better. So the green line, the sequential administration, performed better than the concurrent administration. This is the main message. Then the authors also conducted a quite interesting, even if maybe too much biological, biomolecular and immunological study. But they tried to identify the type of cells that changed during the treatment in both groups. And they evaluated that a particular type of cells, that are cells expressing PD-L1, that means this is the receptor of the immunotherapeutic drugs against which the immunotherapeutic drugs acts. This receptor increases when you perform this you administer this drug concurrently. That means that if you put another drug, it looks like that these cells try to express more this receptor, so try to escape from this drug. This is a sort of mechanism of action. It's just an hypothesis, but it's an intriguing hypothesis. So in conclusion of this trial, they were able to say that it is better to perform the immunotherapy in a sequential way, so after the end of the treatment, than in the same time of chemoradiation. This is the best message that we may take home from this trial. And this is quite important for the future, because the trials that at the moment are still ongoing are trials with sequential administration of immunotherapy. So the patients are treated with the usual treatment with chemoradiation, and then at the end of this treatment, they are being randomized to receiving immunotherapy or to receiving just placebo. These are other ongoing trials. And we are waiting for the results of this trial, because according to these results that I've just presented, it looks like that this could be the good way in which we can position immunotherapy. So in 2 words, immunotherapy is a good drug, but it is best to be administered at the end of the curative treatment when using chemoradiation as a main approach. Is it too difficult, or do you think that we can express in a better way? Chris, what do you think?
Paolo, I think that one, when I first saw that slide some weeks back, I was totally lost. You've just explained it in such a way that I actually follow 99% of it. So well done there for a start. I hear a lot about immunotherapy. I've done for some time now. Never really understood where it fitted into the treatment pathway. I always got told for head and neck that unless it was recurrence, that's where it sat in. I believe what you're saying to me here is this is for either for your first time person that's being diagnosed, then it could be used. So that's got to be good. What about other tumors that are laying dormant? Would this help this? Because when people have head and neck cancer, they may be laying dormant somewhere in the body around the lungs, the lung cancer tumor. Would this help solve that problem as well? Or is it just what you're saying here? It's just for current patients going forward?
Yes, so your question, please correct me if I have not clearly captured your question. You are asking me if these drugs may also be useful to reduce the probability that the tumors comes back.
Yes.
Yes. So this is the way in which we can interpret this data. So we have a good treatment. Chemoradiation is a good treatment. So let's imagine we have a patient with an advanced laryngeal cancer. We are trying to perform chemoradiation, and we put all our efforts to cure that cancer with chemoradiation. We have understood from previous trial that if you add on immunotherapy on chemoradiation during the same time frame, and this has been confirmed by this trial, you are not changing the survival of this patient. But if, and this is some hopes coming from this trial, that putting immunotherapy after this treatment may reduce the probability that the tumors come back, and both at the local regional site, so that the same laryngeal cancer can come back on the same in the same site, but also as a distant metastasis. So this is our hope. These are just preliminary data, so you cannot conclude anything. and you cannot use in your everyday clinical practice. That is very important. We have to wait the results coming from other randomized trials that are expected in the next 2 years to be ready. But at the end of the day, when we will have this data, it will be possible that we will have another weapons in our hands to counteract this tumor, to tackle this tumor and to reduce the probability that they come back and they recur at different sites.
So we look forward to 2026.
Yeah, maybe some data in 2025 also will appear. Maybe some preliminary data also next year about the adjuvant, about the safety and the preliminary activity, and then in the next 2 years, some more mature data and some approval also. We hope for the healthcare system. This is what we hope as physicians.
So we both need to meet up in ESMO in 2026 to discuss it.
Yeah, let's wait next year. Then in the 2026.
So
I'm saving on the agenda.
What about quality of life again around this? Does it make any difference to quality of life? Extending the treatment? Has any impact? Has it been recorded? How does the quality of life look on this?
Yeah, this trial did not present quality of life data. What we know from the use of immunotherapy for such a long time, because if you use immunotherapy for more than 1 year, you may expect some, as I previously said, toxicities or adverse effects or some consequences from this treatment. However, what we know is that these consequences that can impact on quality of life are quite reduced, and they could affect about 10 to 15% of the patient. I'm speaking about adverse effect, toxicities, quite important related to immunotherapy. So 1 patient out of 8 or out of 10 can have his or her quality of life impacted by this immunotherapy. That is quite different from the use of chemotherapy, where the quality of life is more profoundly, more deeply impacted by the use of chemotherapy.
Okay. And the last one, you mentioned that no one can get this at the moment, but would it be available offline if a consultant in a hospital somewhere in the world thought that it was right to do it?
I believe that it will be not correct yet, because we need a huge randomized trial. As you correctly underlined before, the number of patients treated is very important. In this trial, only 60, 80 patients have been treated. We need trial with hundreds of patients treated, because a treatment should be defined as effective when you have strong data coming from a huge number of patients compared.
Perfect. Thank you very much.
Thanks to you. And let's move to the third abstract. We are in a completely different setting. We are speaking about a patient whose disease has recurred, so it's not a good condition. We are speaking about a recurrent metastatic patient. We know that immunotherapy is useful for this patient and can be given by the physician, so in the healthcare system. So when you give immunotherapy, you may expect to achieve a response. However, there are some patients who do not achieve a response to immunotherapy, plus or minus chemotherapy, or who they progress after having achieved a response, and who are in need of another treatment. So this is the background. Patient with recurrent metastatic disease who needs another treatment after having been treated with immunotherapy. And this author tries to employ another drug that is called monalizumab. And they evaluated this drug compared in 2 types of groups. The first groups received monalizumab plus cetuximab, and the other group received cetuximab plus placebo, so no monalizumab. What that means, these strange names? Monalizumab is a drug acting on a particular part of the immune system that is called the innate immune system. So it's a drug acting again in a way trying to reinforce the immunitary system of the patient. While cetuximab is, as previously said, a drug anti-EGFR, anti-epidermal growth factor receptor. So trying to block the key that can enter the door and nourish the tumor. So the authors compared the use of two drugs against one drug. So this is basically the design of this trial. Patients with incurable recurrent metastatic head and neck squamous cell carcinoma treated with these two drugs together or only with one drug, cetuximab, trying to evaluate if the use of two drugs may be better than one. So this is the number of patients treated. It is still quite a huge number of patients treated, as you can see here. But what you can see is that according to this, that is called hazard ratio. When you see an hazard ratio, you should see if this hazard ratio is in favor of one of the two treatments. And you can see, clearly see, if the interval of this hazard ratio is clearly below or above the one. In this case, the hazard ratio is comprised between below and above one, so it's not in favor of the combined treatment, and the same is in these other groups. So what this means that the response of the two drugs is the same that the response of only one drug. And this is another way to see that the adverse effect of combining these two drugs was quite similar, so happening in 38 or 30% of the patient. So at the end of the day, what I would like to show you with this trial is that in this population of incurable patients already treated with chemotherapy and immunotherapy, the combination of two drugs is not better than one drug alone. So why it is important, even if these are negative results. So don't be afraid of negative results. This is a lesson that I have clearly learned during my career of oncologist. Don't be afraid of negative results because these results are very informative. First of all, we know that if we use two drugs, you administer the patient, you give the patient maybe more time to stay in the hospital and a quite higher possibility to have some adverse effects and to have a worse quality of life. So the lesson from this abstract is that if you use only cetuximab after the use of chemotherapy and immunotherapy, you may achieve some results. This is quite positive in my opinion. But the most important results of this trial that I would really like to emphasize is that this same drug that is called cetuximab has been used already in the past in the recurrent metastatic setting as a standalone drug. And the results that this drug was able to achieve were not so good because it benefited one patient out of 10. So it is strange that now we are benefiting one patient out of 4 because the response rate to this drug was about 25%. Why this is very important? Because we learned that if we administer immunotherapy before, then also another drug like cetuximab may increase its activity. And this is the main message. So this abstract gives to me two messages. One message, one is better than two. That is not a bad message for the patient. And the second message, the use of the same drug after immunotherapy may achieve higher response rate than if the same drug was used before immunotherapy. So these are two concepts that I hope that can be useful for the patient too.
Okay, obviously, it's always disappointing when you try something and it doesn't come out the way you expect it. But I go back to quality of life because nothing again is shown in here on quality of life, apart from what you maybe said. So if it's almost identical, I go back to my 70-year-old man that says, I wish I hadn't survived because of what they've done to me and what they put me through. I would rather someone had quality of life than got an extra 1 or 2 years, knowing that their quality of life was going to be even worse. So maybe this is good that it says that it's almost like for like. So let's stay with what we know. Is that how I see it?
Yes, sometimes we try to offer a more aggressive treatment, I would say. And sometimes is justified by the fact that the tumor is very aggressive and the consequences of the tumors may be very discouraging, very important for the patient. The lessons from this trial is also that with only one drug, maybe also in frail patient, in older or frail patient, may be enough to achieve some response. And this could also imply that also the quality of life is improved. We have no data coming from this trial specifically about quality of life, but what I think is that this treatment can justify, in particular in frailer patients, the use of only one drug as a palliative treatment, because if we would like to palliate some symptoms or to reduce the impact on the quality of life, this means for me palliation, to reduce the impact of the tumor on the quality of life of that patient. Because if I have a huge node in my neck, and I know that this node is pushing my pharyngeal axis, I would not be able to eat. I would have pain in my neck. I would have difficulty in breathing. And if using only one drug with a reduced impact on adverse effect or toxicity, and if this drug could be useful for me, then maybe it's better that I use that drug in order to reduce the impact on that symptom.
Perfect. Well, going back to our earlier conversation, I hope in future and not too distant future, when we review these and other patients review it, quality of life has at least half a slide on everyone. Because from a patient's perspective, we've always got to ask about quality of life. And I don't think it's acceptable now going forward that trials are done without putting that quality of life right at the top. So I think it's a great abstract. I like the way you explained it again. I do fully understand it. And, thank you very much.
So I embrace your idea. It would be not acceptable anymore that these trials are presented without quality of life. This is absolutely a message that you as patient association, you as a patient, you should clearly tell us and tell the scientific community. So please put quality of life within the main results of any trial that you present. Because what we know is that sometimes these trials are presented for their efficacy or toxicity only. And then after 2 or 3 years, another manuscript, another papers appears in the literature saying, oh, okay, we have also quality of life of that trial. Okay, but my question is, if you have quality of life, why haven't you analyzed immediately and presented with the first results of this trial? I perfectly agree with you. And sometimes it is also our fault. Sorry for not being able to push enough.
I think maybe ESMO needs to take that aboard. ESMO science side of the ESMO needs to take that message when people are presenting abstracts for review. Maybe that needs to go out there to see if they have got quality in life. And if they haven't, why they haven't. Maybe that will start change.
I agree, perfectly agree. So let's move to the last discussion. It's quite different. This is quite interesting. I would say that this could impact in the future the way in which we follow our patient after the treatment. I speak about ctDNA, so circulating tumor DNA is an assay to detect the so-called minimal residual disease after curative therapy. What is minimal residual disease? We know that after the end of the treatment, it is possible that the tumor disappears. As we know, if you take off this tumor with a surgical operation, or when you perform a radiation or chemoradiation, you try to put the tumor off and this is sometimes we are able to achieve this objective, that is the cure of the tumor. But we do not know if there is something that is at the cellular level or in a more specific way at the DNA level. It is possible that the disease could be in a sort of minimal residual disease. And till now, we had not so many experiences speaking about the detection of this minimal residual disease after the treatment. And this is the object of this trial. So the authors analyzed samples coming from 53 patients who underwent a curative intent treatment. And they analyzed these samples looking at the MRD, so the minimal residual disease, that was defined as the detection of one sample collected after the end of the treatment with this DNA present in that sample. And they tried to correlate if the detection of this DNA in the blood was also linked or not to the fact that the tumors come back or not. So basically, first message of among 53 patients before starting the treatment, because the authors evaluated these blood samples before the treatment and after the treatment. So they evaluated the presence of this ctDNA before the treatment, and they were able to identify in 77% of the patient. That is a quite high percentage. However, this means that this test is not for all the patients, because we are leaving off 23% of the patient who can be offered this test, but where the test is negative because we cannot find this disease before the treatment. And after that, the patient performed the treatment, and they reanalyzed this minimal residual disease as detected by the presence of ctDNA. Obviously, they evaluated only the 41 patients where this marker, this assay, was positive at baseline, and they were able to find that 17 out of 41 patients had this marker positive in the blood. That means that this could be a way to say that the disease was present in a minimal residual way after the treatment. And they were able to show that this minimal residual positivity was an independent predictor of relapse. So after the treatment, if you have the blood samples positive for this ctDNA, then you have a higher probability that the tumors come back. This is the main results of the trial. What I would like to tell you is that the main conclusion is that this could be an analysis tool, an assay that could be easily applicable in daily practice, because it is a simple blood sample taken from the patient. What means for everyday treatment? These are preliminary data. So again, sorry, you cannot use tomorrow in every hospital as a standard approach, but is only for matter of research until now yet. But the use of this liquid biopsy can be important to identify the patient who will relapse and patient who will not relapse. And how can I imagine to use this tool? I may use this tool because if I know that the patient has a higher probability of coming back his or her tumor, then I will follow him or her with a more close follow-up. So I may visit him every month. I may ask for a radiological imaging more frequently. And on the opposite, if I have a patient whose minimal residual disease is negative, I may be more safe in telling him or her that his or her follow-up may be more relaxed. And also from the psychological point of view, this is quite important, I know from the patient perspective. This is, however, something that needs to be confirmed in larger samples. As you correctly point out at the beginning, Chris, we are speaking about 53 patients, so not hundreds of patients. And before being able to use this test in everyday clinical life, we need hundreds of patients treated, and we need to say that this benefit is real, and that there are no drawbacks from the use of this test, because this is very important for the safety of our patients. But this, for me, it's a really matter of hope that for the future, in, I don't know, 5 to 10 years after the end of the treatment, we will evaluate only blood samples for the patient, and we'll try to tailor the follow-up programs for this patient. And the tailored program means that maybe I will be able to detect a recurrence earlier than I am able today, and I will be able to offer a curative treatment even if the tumors comes back. This is the main message that I take home from this trial. What do you think, Chris? This is good for your opinion, or it is a lot of questions or negative impact that you see?
No, this out of all the extracts I read and I've seen this over the last 12 months, excites me the most, but it also worries me the most. So I done a survey about 6 months ago to patients that if you could have a blood test and they could tell you whether your cancer was going to come back or not, would you want to know? We had 125 people that replied to the survey, and over 90% said no, they wouldn't want to know. So I see this as a helping you, but a lot of people said it would be like waking up every morning with a gun to your head and pushing the trigger and no bullet comes out until a bullet comes out. So a lot of patients didn't want to know it. And when we asked the breakdown of male to female, majority of the ones that did want to know was female, and the males were almost zero wanting to know. So I do think there's a lot of work to be done on how and when this will be used. I think it's a great tool for our health professionals, but I think there's a lot of work to be done whether patients would want to know from their DNA whether they're going to get cancer coming back, because I believe what you can't tell them is when or if it's guaranteed to come back to a point where you're going to need treatment. All it's saying is there's something in the blood that is cancer. That frightens me. Your thoughts on that?
That's an important point that you raised. I believe that this is very important because you're right. What I think is that if we are able, as a healthcare professional, not only to present the possibility to have this test, but to couple this test with a therapeutic intervention. So if I am able to say, okay, we have a higher probability that the tumor comes back, but I have an adjuvant treatment that can help you to reduce the probability that the tumors comes back. And this is linked to the second abstract I presented. If at the end of the day, immunotherapy will really be important to reduce the possibility that the tumors relapse, then I would be more prone to offer this test to my patient and to tell him or her, okay, you have this probability, then that the tumor higher probability, but you may be treated with immunotherapy and you could reduce, you could lower this possibility and be more happy about the possibility that you have been cured from this cancer. So I believe that the two results are really close, very, very close one to each other.
Yeah. I honestly believe you can't have one without the other. You've got to, if you're going to possibly identify a problem, you have to have a solution. If you can't have a solution with finding a problem, then you shouldn't find that problem. I don't believe. And our survey held that out. Now, all right, like you say, it was only 125 people, but it was 125 people that had cancer that we were asking whether they would want to know whether it was going to come back, and the majority said no.
Oh, Chris, this is, for me, is very, oh, you have opened a lot of questions also for me, because sometimes we are really so excited from some results, but we cannot perceive the importance of what we change in the patient mind.
Yeah. And
You're right.
share offline, I'll share the survey with you so you can see that survey. And I do think if this is going to go forward, I think the scientists around the world that is working on this needs to remember that if there's a problem, you need to have a solution to go with it.
Yeah, that's perfectly correct. If I think that the message you are giving to me is that if you are putting a lot of energy on this type of research, please put the same intensity of energy in trying to couple the results with a positive opportunity to give this patient, this negatively selected patient.
And also whether patients want it and the public want it, because it's not the patients now, it's our patients of tomorrow. We need to find out on a bigger survey whether the person that's not got cancer today or got cancer would want to know this if it happened. And I think the research needs to do a piece of work around that, because otherwise it's very exciting, but it's also very scary. And what I wouldn't like is a lot of money spent on this, on the research, and then when it goes to fruition, patients say, I don't want it, I don't want to know.
No, thanks. This is very, very good. So let's stay connected. You are reinforcing the message that the research should be very connected, intensively speaking to the patient association and patient, trying to understand what really means for their life.
Yeah, I think it's very, very exciting, but I think we have to be very cautious.
Yeah.
Thanks
for this message. Thanks to you.
I personally would like to thank everyone for listening, who's took the time to listen to me and Pablo out there talking. If you've got any questions, anything else, you can go through ESMO, and we look forward to seeing you at another time. I don't know whether you want to finish off with some words, Pablo.
No, I would like really to thank you, and because it's important, every time I speak with the patient, I know that my point of view maybe should be more broad and and any type of research should be conducted with the patient close to me. Thanks again.
Perfect. All the best. Thank you very much.